we have Dr. Deborah Katzman and Dr. Chipatli Ayuso. Deborah and Chipatli are going to talk about food as medicine, why and how you can do this. Deborah Katzman is a professor of paediatrics in the Department of Paediatrics and University of Toronto and senior associate scientist at the Research Institute at the Hospital for Sick Children, known as Sick Kids. In addition, she is a member of the Institute of Medicine at the University of Toronto. Dr. Katzman co-established the Eating Disorders Program at the Hospital for Sick Children in Toronto in 1993 and was the director of the Eating Disorders Program from 1993 to 2012. She was the head of the Division of Adolescent Medicine Sick Kids from 2004 to 2012. Deborah is the Director of Health Science Research in undergraduate medical education at the University of Toronto. Chipatli is also a paediatrician with a master's degree in children's nutrition. She is the mother of a teenager in recovery from an eating disorder. She is an advocate and activist in Mexico, empowering parents to help their beloved children. Chipatli is passionate about spreading information to other physicians about eating disorders and the importance of parent involvement. And lastly, Chipatli is the liaison for Mexico on the F.E.A.S.T Global Task Force.
First of all, I want to thank you so much, Gordon, for that lovely introduction. And I want to say good morning to everyone. Good morning and good afternoon and good evening, depending on where you are. I'm so thrilled to be with you today, and I'm excited to present this session with my colleague, Dr. Ayuso. I want to thank F.E.A.S.T, and in particular, I want to thank Laura Collins, Leister Mensch, and Nikki Wilson for the invitation and for the incredible work that the two of them has put into making Feast of Knowledge a reality at this unprecedented time. It truly is an honor to be speaking to you. This is my disclosure slide. I have no potential for conflicts of interest within this presentation. Now, it is my hope that all the participants by the end of this presentation will be able to appreciate why food is medicine in children and adolescents with eating disorders and understand the impact of an eating disorder on a young person's growing and developing body. I'm also hopeful that you'll be able to appreciate the importance of food in the treatment of child and adolescent eating disorders and understand the energy needs of these young people who suffer from these disorders. Now, before I jump into the essence of this talk, which is food is medicine, what I was hoping to do is talk a little bit about why eating disorders in children and adolescents are so vitally important. Eating disorders are identified in younger and younger children. And in studies that we've done, and this is one of the studies that we've done, we have actually shown this. In a population of young people who are less than 12 years of age, you can see that eating disorders actually do exist in young people. And they exist in young people who are as young as 4 years of age. The other thing that I want to point out here is that with increasing age, there's an increasing prevalence of eating disorders. And finally, both young girls and young boys develop eating disorders. Now, the clinical presentation of eating disorders in younger people is quite unique and very different than what we see in adults. These young people have significant medical and psychiatric consequences, which, if not identified early and treated aggressively, may not be reversible. Now, as a pediatrician and other health professionals in the audience and parents, you're going to see young people with eating disorders because eating disorders are the third most common chronic illness in adolescent girls after obesity and asthma. Eating disorders have the highest mortality rate of any psychiatric disorder, and young people with anorexia nervosa are 10 times more likely to die compared to their healthy peers. Now, the premise of my talk today is that food is medicine. And food is medicine for children and adolescents with eating disorders. And nutrition is the first-line treatment for eating disorders. And I'm going to use food and nutrition synonymously. Therefore, food is the first-line treatment and food is medicine for young people with eating disorders. Now, one way to really understand this concept of food as medicine for young people with eating disorders is to look at other life-threatening illnesses and the role of medicine in these disorders. Let's look for an example at childhood cancer. Chemotherapy saves the lives of many children with cancer, for example, leukemia and lymphoma. And not giving chemotherapy can cause severe side effects, including death. Therefore, chemotherapy is a necessary treatment for children with cancer. What if we substituted chemotherapy for food and childhood cancer for eating disorders? Well, food saves the lives of children and adolescents with eating disorders. By not giving food or not giving enough food, that can cause severe side effects, including death. Food is necessary to treat children and adolescents with eating disorders. For young people with eating disorders, food is the medicine. So, how much nutrition and how much does it matter? So, if we don't have nutrition, what happens to these young people is they develop medical complications. They're unable to engage in meaningful treatment. They become quite isolated because in young adolescents and adolescents alike, a lot of social interactions are around food. They develop abnormal eating attitudes and behaviors. And in studies that we've done, we've shown that these young people, along a number of neurocognitive domains, develop deficits in their cognition. And they also develop mood changes. But what happens when we feed young people? Feed young people food as medicine. Well, it reverses these medical complications, and these young people are then able and capable of engaging in treatment. They're able to reach out to their peers, and they're able to reach out to trusted adults. We can begin to help them normalize their eating attitudes and behaviors, and we can lift those cognitive deficits and help them with their mood. What we know is that eating disorders, especially those who are not eating well, can lead to serious physical and psychological complications. Every organ system in the body is affected, and you can see here in this slide, both anorexia nervosa and bulimia nervosa, every system in the body is affected. And in children and adolescents, there are unique medical complications that are specific to this age group. These young people can have impairment in their growth. They can have delay or interruption in their pubertal development. They can have low bone mineral density or brittle bones. And they can have structural and functional brain changes that occur. Let's look at these a little bit more specifically. Let's look at growth in young people with eating disorders. We know from studies that have been done that growth hormones do not work properly in young people who have eating disorders. And at this point, studies are pretty inconsistent with respect to whether or not young people can actually attain their full growth potential. But what we do know from some studies is that continuous uninterrupted nutritional rehabilitation can actually normalize growth hormone and allow young people to attain their full growth potential. In essence, the treatment here, food is medicine. What about pubertal growth and development? Well, young people who develop an eating disorder prior to the onset in girls of their menstrual period or in young boys do not have normal sexual development. It's often delayed. And in young girls, their periods are delayed. What happens to young people who develop an eating disorder after their menstrual period starts or in boys later on in their pubertal development? Well, there's definitely interruption of normal menstrual function in girls and interruption of normal pubertal development in boys. So for girls, breasts stop developing and there's lack of pubic hair. In boys, the gonads and the penis start developing and there's lack of pubic hair there. The one way we know how to reverse this is by food. Food is the treatment. Food is the medicine. Let's take a little bit more of a dive into menstrual function in girls with eating disorders. We know that menstrual dysfunction occurs across all eating disorders. Now, amenorrhea, or the lack of a menstrual period, is no longer a criteria for anorexia nervosa. However, I can tell you in our patients, most of the young people we see with anorexia nervosa don't menstruate at all. And amenorrhea, this lack of menstrual periods, is associated with low calorie intake, high exercise, and low body weight. Infrequent or light menstrual periods, also known as oligomenorrhea, is associated with a number of eating disorders as well as behaviors. So anorexia nervosa or binge eating disorder, but it's also associated with vomiting or the use of appetite suppressants. What can result from an abnormal menstrual period or menstrual dysfunction? Well, low bone mineral density or brittle bones. This is a serious and frequent and early consequence of anorexia nervosa. And in studies we've done, we've shown that young people as early as 3 months into the illness can develop low bone mineral density. This can impose lifelong limitations and considerable morbidity, including a risk of fractures. Now, healthy adolescence is really a critical window in the time to optimize bone mineralization. However, if one were to develop anorexia nervosa during this period of adolescence when they should be gaining bone, there's great concern that these young people will not reach their peak bone mass and therefore not reach their full bank and go into adulthood with low bone mineral density or brittle bones. We know that young people who develop an eating disorder, either during childhood or adolescence, have low bone mineral density at one or more skeletal sites. We know that if you develop an eating disorder during childhood or adolescence, you're not going to increase your bone mass as you normally would. And this puts you at increased risk for fracture and morbidity. The one thing we do know about this is that food is the medicine. Nutritional rehabilitation is the best and safest treatment for low bone mineral density. What about brain structure and function? Well, studies we've done have shown that in acute anorexia nervosa, there's greater fluid around the brain and less matter, less gray matter and white matter. And we know with food and medicine that some of this is recoverable. This helps reverse the findings. Let me show you here. This on top are young people with anorexia nervosa. This is a 14-year-old, this is a 15-year-old, and this is a 16-year-old. On the bottom are healthy controls. What you see here are ventricles, and these ventricles are structures that actually produce cerebrospinal fluid. They produce the fluid. It's much greater in young people with anorexia nervosa than it is in these healthy adolescents. And you can also see they have a lot more fluid around their brain as well. That's the white compared to the healthy adolescents. The treatment here, folks, is food is medicine. Now, when I see young people come to our clinic who are very sick with an eating disorder or restrictive eating disorder, many of them are taking less than 500 kilocalories per day. And that's relatively having a diet that's low in fat and low in carbohydrates. Protein is often spared as a percent of their daily caloric intake. These young people often are vegetarians or vegans. They present as being lactose-free or gluten-free or intolerant or have allergies, and we need to explore that. They may have similar food choices every day for every meal. They count their calories and they count their fat grams, and their eating is often very ritualistic, which means, for example, they may take small bites of their food. They may tear their food into tiny pieces. They may over-season their food. However, what we know is that nutritional restoration is the key component to reversing these types of behaviors and this quantity of energy. Now, the caloric needs, or energy needs, as we call them here at Sick Kids, of adolescents recovering from restrictive eating disorders are very high. Adolescents with anorexia nervosa are what we call hypermetabolic, which means that their body burns and requires more energy to function. And this can occur up to 2 years after they achieve their weight restoration. It's not unusual for the patients that I see to require anywhere from 3,000 to 5,000 calories per day to achieve effective weight gain. So how do we approach this? Well, we approach it systematically, and a systematic approach to prescribing medications or food is the way we go. So I'm putting on my pediatric hat now. The way I would approach this is I would identify the problem, I'd specify the therapeutic objective, I'd select an appropriate treatment, I'd initiate that treatment, I'd provide the parents and the young person with information and instructions and warnings, and I would evaluate the therapy regularly. So let's take a common problem like an ear infection, which we've all had or our children have all had. So that's the problem, and the objective here is to resolve the ear infection. And we do that with the drug or therapy of amoxicillin, an antibiotic that we give at 500 milligrams a day orally. And we make sure that the parents know that there may be some stomach upset and they need to finish all of the medication. And we evaluate it regularly. We ask the parents to make sure that the fever goes away and that the child is without pain. And then as a physician, I would evaluate the ear at the completion of therapy. Well, what about an eating disorder? Well, identifying the problem, let's say it's anorexia nervosa. The therapeutic objective here is weight restoration, and the treatment is food. 3 meals, 3 snacks a day, and the parents need to increase that as needed. What the information I give or instructions I give the parents are, you're in charge, you need to support the young person, you need to be involved, and you need to closely monitor. And the way we evaluate that is by weight restoration. Further down the line, we'll look at their eating attitudes and behaviors, and we evaluate their mental health. When we think about nutritional rehabilitation, we think about where we're going to do this, inpatient, outpatient, or day treatment. But the message I want to send home today is that what has changed over the last few years is that if a child is admitted to hospital, we can treat these young people with higher caloric refeeding needs, because we've found through evidence-based research that it's safe, effective, it provides better weight gain and shorter hospitalization so that young people can leave the hospital and start the first line outpatient treatment, which is family-based therapy. So I hope I've convinced you why food is important and why it is medicine. We want to delay any of the medical and psychological and social complications. We want to reverse them by identifying early and treating with food aggressively. And the longer the eating disorder persists, the harder it is to treat. So the take-home messages today are eating disorders are one of the most fatal mental health disorders. Children and adolescents with eating disorders can develop medical and psychological consequences if these disorders are not identified early and treated aggressively. The energy needs of children and adolescents with eating disorders are high, and the only way that we can treat this initially is food. Food is medicine. So thank you for the opportunity to speak with you.
Hello, my name is Cipatli Ayuso, and it is a pleasure to be here with you on this side of the screen. 2 years ago, I was a parent learning from the experts on the other side of the screen. It was Chicago 2018, and as you know, eating disorder does not respect any titles or professions. My only daughter was diagnosed with an eating disorder. And I remember attending Feast of Knowledge in tears, feeling depressed, feeling tired, and feeling with a lot of guilt. And my husband and I, even though we were pediatricians and experts on nutrition, it was the voice of the parents who really helped us to know what we should do in order to help my child. It was the voice of the ones that had already lived in my shoes, that had already fought the battle against eating disorder, who helped us by their experience and to teach us how to fight this disease. So the journey was hard. I can tell you it's the hardest thing we've ever done as a family. But the reward of having now a healthy teenager smiling is worth it. And the first symptom I noticed on my child was the silence of a previous noisy child. She hadn't lost, but her mind was thinking different. It was periods that she was like really quiet, and there were other aspects that I knew that something was wrong. And this is one of the researchers that Dr. Deborah talked us earlier. And even though eating disorders have existed for centuries, it is only in the last decade that we have known more about eating disorders. And I am not talking only about anorexia. This paper I have right here, that I love it because of the title, is one of many studies that are being done at UCSD. And what they do is that they do different researchers checked by MRIs healthy brains, and they compare to others that have different eating disorders. And they give different stimulus to see how the brain interacts. For example, they give images of food, or they put the images of their own bodies in the mirror. Some of them taste and give some glucose to see what happens on their brains. And what we know now is that there are different pathways and neurocircuits and different chemical reactions that happen in those that have eating disorders, so that they think of food different than we do. Usually what happens in the brain is that when we start having low blood glucose because we haven't eaten for a certain amount of hours, then our body starts feeling hungry. And when we start eating, we start feeling better. We start feeling the reward of tasting something that is healthy. In different eating disorders, these pathways won't work the same way as they will work in a person that is healthy. So the glucose needs, the brain needs glucose in order to function. And the more the brain is starved, the worse these pathways function. And the body will break down proteins or fat to get this glucose that it's not receiving in the food. And if not, it will even break down neurons and lead to a brain shrinkage if necessary. There are other researchers in the last 3 years that have been studying the relationship between the gut and the brain. And there is something that is called the gut-brain axis. That it means that some of the bacteria that we have when we have a wide variety of foods, that bacteria makes some substances that help the brain to produce some neurotransmitters such as dopamine and serotonin. Being serotonin one of the main neurotransmitters, usually when we have these substances in our brain, that make us feel hunger and feeling fullness. But it also can lead to some delusions. And for example, in binge eating disorder, if serotonin is not working correctly, they just won't feel the fullness you usually do when you eat a certain amount of food. In anorexia, for example, sometimes they don't feel the same hunger as we do when we need to eat. And the more serotonin the brain has, it also has some delusions in these patients. For example, dopamine is the responsible of happiness, satisfaction, reward, and pleasure. But we also know that the dopamine is responsible of some auditive hallucinations that make some noise in the brains of people that have eating disorders. And these hallucinations can be as bad as the ones that people that have schizophrenia experience on their disease. When we say food is medicine, we refer to every single group of eating disorder. And we know that these pathways are not working okay, and all of them lead to distress and anxiety by different pathways. One of the common behaviors we see, especially in patients with anorexia, these are the ones with anorexia, are that they start different diets such as being vegan or start something they call clean diets. They start counting calories or complain of different stomach aches. Sometimes they exercise too much in order to burn those calories. And they're very interested in cooking shows or cooking books. They have different concerns on their body image, change in eating behaviors. Sometimes when you have a lot of anxiety, we're going to put an example. For example, we don't want to get coronavirus. So when you're very anxious and you're afraid, you start doing certain things that make your brain be more calm. Washing your hands and avoiding certain places and things that you think they're going to help, and some of them do, to stop or to avoid the virus. And the people with eating disorders, they also have certain orders or certain behaviors that they think they can help you to avoid the anxiety food makes them feel. They also have shame, especially those persons that have bulimia, or when they finish eating a large amount of food, for example, in binge eating, and they feel shame. And a lot of them have something that in medicine we call anosognosia. And that refers to not being able to know that there's something wrong with you. A lot of patients could be really sick and they cannot express that they have a problem. And that's why we don't have to wait until a patient expresses that they need help in order for us to diagnose promptly and to help these patients. And what do we need to do? Well, exposure therapy, or food in this case, is the same as making a patient that has arachnophobia to be exposed to spiders. And it's the same with food and eating disorders. When somebody feels a lot of fear, what happens to these people is that they want to run or scream or fight back, or they will just faint or paralyze, or even self-harm, because when they harm themselves, they stop feeling this anxious, and sometimes they feel they need to be harmed because of the action they just done. So as Dr. Deborah told us with the example of the patient that had an ear infection, the same happens with different diseases. For example, when we have a bacterial infection, we need an antibiotic. And that antibiotics need a specific dosage, a specific compliance, and it does have side effects. And of course, the antibiotic has different dosage depending on the diagnosis, the weight, and a specific person. And you cannot say, okay, I'm not giving this dosage, or instead of giving it every 4 hours, I'm going to give it every 6 hours. And you cannot skip doses, and you cannot skip side effects. For example, in diabetes type 1, The patient needs to get their insulin on a daily basis. And you cannot say, okay, today, because it's her birthday, it's not going to have the insulin shot. In leukemia, sometimes side effects is even worse than the disease itself. The chemotherapy makes the patient feel nauseous, and they start having balls and hair loss and things like that. And the same happens with food and eating disorder. You have to keep a specific amount of calories, and you have to feed your child in specific hours, and you cannot skip a snack. You cannot say, okay, I'm skipping this snack and then I will give a little bit more on the dinner. Or you cannot say, okay, today we're not gonna eat the specific amount of calories we need. We're skipping today because we're having a birthday, and tomorrow we'll do it. And of course it's gonna have side effects. Being side effects, anxiety, distress, and sometimes this anxiety and stress is even higher than the disease itself. So what do we need to include in the diet? Well, it has to be food that has all nutrients, carbs, protein, fat, water, vitamin, minerals, and we have to stop some dietary restrictions, promoting gain weight, approximately 500 to 1 kilos per week in case you want to refeed a patient with anorexia. And in the case of patients with binge eating disorder, then you have to see the specific amount they need in order for the insulin won't make those peaks and make those patients eat more or in a binge purging cycle. You have to stop the excessive exercise and limit other eating disorder behaviors. And anxiety is going to be way high. So, what do you need to know as a parent? That you're going to start a battle, and you have a warrior, and your warrior has weapons. Being a warrior, for 1 second, close your eyes and think of a warrior that is a perfectionist, that wants to avoid conflict and is super smart. But this warrior has also fear. And the worst is that this warrior has your child's body, your child's voice, and your child's face. So in order to win this battle, you need to be a better warrior. And you also have weapons. And your weapons are that you have the knowledge of the right. We can be experts in eating disorders, but you are an expert on your own child. It's your rules, not their rules. You have a team, and your team has to have a physician, a dietitian or nutritionist, a psychiatrist, and a lot of people that are going to help you that are right here with you, sharing these slides with you. It's your territory because it's your house. And the most powerful weapon you have is food. It's going to be a terrible battle. Oh, yes, it's going to be. But the reward is your child's life. So it's worth it. Thank you very much.
Thank you so much to Partly and to Deborah. Look, fantastic information there, ladies. Thank you again for all your time and preparation. Those of you who are watching the program, we're due to finish very shortly, but because it took us a while to get a few technical issues sorted out and a late start, I'm just going to let this session run over about 10 minutes to field a few questions that have come in. Deborah, I hope you can hear me. That's my only concern with this. However, we will press on and see where we go. But some fantastic questions. Look, the first point I just want to pick up coming in from the chat functions and the Q&A function is some parents out there do understand that food is medicine, but it is still a horrific journey to get through. And even if you understand that, getting your loved one to eat can be a challenge. If our speakers want to comment that, please feel free to do so in a moment. But I'll start with the first question that's come in from Joanne, and it was sent in as part of the questions before the webinar. So I'm just going to read this because the print is very small. Why is it that some people notice a big improvement in their family member's state, mentally and physically, once getting nutritionally restored or to a good weight, and for others it seems to take longer to see any improvement? Can you provide some comment on that, please?
Yeah, well, there are other studies that I didn't mention that have been studied, different medications, psychiatric medications. And we know that when we start these medications, later on the refeeding, it has better results than the medication itself. Food is medicine. There is no other medicine that's going to help your child recover an eating disorder. But you can have help from other drugs, especially if the patient has other morbidities, such as if they have obsessive compulsive disorder, or if they're struggling with other things, then those medications do help. I see that somebody's asking if we did FBT at home. Yes, we did. We were also in a clinic that helped us know what we need to do at home, but mainly the job we did was at home. And yes, it's hard. You're going to have food thrown up at your face. And I remember my daughter yelling at me, "I hate you, I want you to die," and things like that. And now she doesn't remember anything of that. Of course, I'm going to remember the rest of my life, but it's okay. I see her smiling now, and it's a lovely child. She went back to school. She skipped school for some months, and she's doing great. So if you hear your beloved yelling at you, it's not your beloved. It's the eating disorder that is angry at you because you are fighting really well.
Okay. So the next question has come in from Akana. When we achieve the weight goal, but the behaviour towards food items has still not changed, should we force the issue or focus on weight maintenance first, then after the second wave of anxiety passes, try to add anxiety-inducing foods, then focus on personal hygiene or exercise? Or should we try to do all at once?
Okay, great question. You need a team, because we need the dietitian and the psychiatrist and the physician to work together with parents, because they have to decide if they can start adding more calories to their diet, or if you are gaining the 500 grams per week and you are doing okay and she's doing better, then you have to know when to start exercise or to stop adding calories to the menu. But this has to be a teamwork. There is nothing that tells you, oh, this height with these kilos, because every person works different. We know as parents that when we do our 110% of weight goal is much better than when we stop on the 100.
Okay, thank you. Deborah, I understand that you can hear me now somehow. Can you just let me know if you heard those questions?
Hi, Gordon, can you hear me?
I can, very faintly. I don't know if tech team can help with that. But it's just, I can hear you, so do you want to keep talking?
Sure. I just got on, so maybe you could repeat the question. I'd be happy to take a stab at answering it.
Yeah, so there were two questions that had a similar theme. The theme was, as I am interpreting the question, so to our attendees, I apologise if I'm misrepresenting it, but it's around if you get the person to a certain weight, but some of the I'll use the word traits of healthiness have not yet returned, do you continue with the eating or not? And in a similar vein, why is it when some people get to the expected weight of that, when health is expected, some people seem to show good health in their attitudes and behaviours and other people don't? And what to do about that?
So that's an excellent question, Gordon, and that's a question that I get asked a lot, especially from my patients and from my families. I think if you've reached the expected weight that the team thinks is a good weight for you, and you haven't resumed sort of normal health or normal menstrual function, I think it's an opportunity for the team to re-look at that expected weight to see if it's the right expected weight. And then you ask, well, how do you actually do that? And I think because we're dealing with children and adolescents and they're constantly growing and developing, it's really important that you reassess that every 3 months. One of the things that we do at Sick Kids, in girls especially, is if we think that a young person has reached the right expected weight but hasn't their menstrual period back yet or is not growing and developing from a pubertal standpoint, what we'll do is we'll get an ultrasound of their ovaries and their uterus to see whether or not they are growing and developing. And there's some pretty interesting work from the UK that has shown that if the uterus and the ovaries aren't at the stage where they're adult females yet and there's dominant follicles there, then they may not be at the right weight. And you as a team with the parents are going to have to reassess that and maybe push forward with more weight restoration.
Okay. Thank you. Look, we're getting a lot of questions about, we all get this, we know food is medicine, but what do you do about getting the person to eat? I don't think that was the topic of your talk, but please, those people who have put those questions in, we truly understand how difficult that is, and we hopefully will cover some of that in later presentations. I'm wondering whether the next one about the superpowers of parents may in part address that. But the other question that has come in, and this may need to be our last question, but let's see how we go, is if food is medicine, the theme is of the question is, at what age does food stop being medicine? So we're talking about FBT. We know FBT is not the treatment method of choice for adults. So what do you do when the person, reaches 18 and you no longer have that parental direction, control? I think you get the gist of the question. How do you, at what age does food stop being the best medicine? Your thoughts on that, please?
I would say food is medicine for every age and every diagnosis. And sometimes when they are adults or when they don't live at our houses, we have special contracts that we do. Sometimes if they receive money from parents, then we start saying, okay, you're gonna have this privilege, but first you have to eat this and that. And it was harder when they are adults, but I still think food is the first medicine, and then we can look for other medications. I don't know what Dr. Katzman thinks about it.
Yes, Deborah, your thoughts?
Yeah, Gordon and Dr. Ayuso, I couldn't agree with Dr. Ayuso more. There is no age associated with the tagline, food is medicine. Food is medicine. It is the one way in which we know we can reverse these medical complications. There's obviously other medicines and other treatments that we use, but for the sort of physical being and psychological being, the first line of treatment has got to be food, no matter how old you are.
Okay, look, thank you very much. Look, regrettably, we need to wind it up at this point. We've had so many questions come in, which is just a tribute to both of you for the quality of what you had to say. Lots of questions is an indication of interest in the topic. The other the comment just there about the food as medicine for adults, I could suggest that the people asking those questions tune in this afternoon Sydney time to the panel discussion on the different therapies where we look at FBT, TBTS, CBT, ED and DBT. Some of those, three of those four therapies are in use for the treatment of adults or older adolescents. So maybe in that discussion, there may be some things that will help people there. Chipatli and Deborah, thank you so much for kicking us off today on what's going to be an exciting day, and the interest that you've generated with the questions and everything else. Wherever you are, can you please give our speakers a virtual round of applause, and we thank you very much for that. We'll be back shortly. It's at 8:15 Sydney time. According to my clock, that's in 5 minutes, to hear from Lucine Wisniewski and F.E.A.S.T own Laura Collins-Lindstrom-Est, where they will discuss stress tolerance and parental superpowers. We'll see you shortly.
Thank you.